Thanks very much for coming back. We're going to have the second session now, which is about cross-national differences. As you'll have heard so far, it's a major issue as far as ELSA is concerned. The comparison with the US and with other countries, I think, is very fruitful in this area of aging research. And I'm delighted to invite Mauricio Avendano to give the main presentation. He's going to be talking about cross-national differences in health at older ages, the role of public policies. Mauricio is a professor at the University of Lausanne, where he also directs the health policy unit, and he's a visiting professor at King's College London and also at Harvard as well. So I'm very pleased that he's been able to join us today. Thanks, Mauricio.
Thank you very much, Andrew. Thank you very much to the ELSA team. It's really a pleasure to be here at the celebration of the 20 years of ELSA. And really thanks for this opportunity to talk about cross-national differences in health. I think there are quite a lot of people in this room who's done research on this topic, and I hope to do justice to a little bit the research that has been done in this area. So what I would like to do today is essentially to try to put two themes together. So the question of cross-national differences in health, but this is also a topic that I got interested quite early in my career, actually during my PhD, but actually led me to this question of how public policies actually impact health. So what I'm trying to do is to try to bring these two areas together. But I thought maybe before going into the substance, I thought it would be good for us to try to understand what do we refer to when we think about cross-national differences in health. And I think this is quite well illustrated by looking at tables of life expectancy. Before we actually had ELSA and SHARE and the HRS sister studies, the only way that we could compare health across countries was really to look at mortality and life expectancy. And this is well known to you. This is life expectancy at age 65 for Japan. And what you see here is this impressive increase in life expectancy since the 1960s until today. Now, we see the same kind of increases in countries like France, Switzerland, Sweden, the UK, Denmark, and the US. So all of these high-income countries have experienced these major gains in life expectancy at older age. But what we see here is that these gains in life expectancy have diverged over time, particularly for women. And we see a really large difference. So, for example, the black line is the US. And if we compare the US to Japan in around 2020, we see a difference of 3.8 years in life expectancy. This might not look very much to you, but actually this means that the US had the life expectancy that Japan had 26 years before. So it's a huge difference in the evolution of life expectancy across countries. Now, these differences are very dramatic for women, but actually are also present for males. So on the left side, we see that the differences are also there present for males. Less divergence, actually, for example, American men have always tended to be relatively low in life expectancy as well as the UK, but we see that these differences also apply to men as well as to women. So this is kind of the background to this question of cross-national differences, but I thought it would be useful for us to start thinking of the question first. So why is this important? Why do we care about these differences across women? And some of you will know the World Happiness Report of 2023, which tells us, for example, that Finland, Iceland, and Denmark are the happiest people in the world, despite having less than 6 hours of sunlight during the winter. But beyond the weather, I think there are reasons why these comparisons are important. So one of them is policy. You could say to improve in anything, we need inspiration. So we look at these countries like Japan, and we see that they are thriving in terms of aging and life expectancy, and perhaps we want to do better. You can also look at the other side of the coin, which is what is called sometimes in the literature international shaming. We do this very much sometimes with the US, which is like to motivate action into health is to show, okay, look, these other countries are doing much better. And in general, I think what it helps us to is to try to identify the impact of public action. How do public policies actually impact health? Now, there is also a scientific kind of puzzle that is useful for these comparisons. We can go beyond the individuals to look at the impact of policy or culture or environment, political or social systems. And I think that the second one, which I find quite interesting, and I come back to this towards the end, is methodologically it also helps us with causal identification. So we can compare countries who have experienced different policy shocks, environmental shocks, economic shocks, which are somehow outside of the control of individuals, but generate changes in smoking behavior, carrying behavior, decisions to go to school. And these comparisons across countries enables us to look at the impact of these factors on health. Okay, so with this kind of background in mind, I'd like to talk a little bit about what we learned from the ELSA study as well as the HRS sister studies. And I think it's fair to say actually that these studies have enabled, if we can say it in this way, the discovery of cross-national differences in health beyond life expectancy. And the most famous paper that I think that you all are familiar with is a paper that was co-authored by James Banks, Michael Marmotzi, Oldfield, and James Smith, which compared disease and disadvantage across the US and England, published in JAMA. This is a famous graph that many of you have seen, in which we see the distribution of different chronic diseases across income for England and the United States. And apart from showing that there is a gradient in each of these two countries, what it's interesting to see here is that across all levels of income, actually Americans have a higher prevalence of, in this case, heart disease, diabetes, and cancer than corresponding English adults. This is true very much for low-income adults, but it's also true for rich Americans, let's say, if you want to call them like that. Even high-income Americans have higher prevalence of these conditions than corresponding Europeans. Now, you might say, well, maybe this is just the result of reporting bias, and maybe in the US, people are more likely to be screened for some of these conditions, and they're more likely to be aware of them. So what's really valuable, I think, of the ELSA study as well as the HRS is that they actually collected data on biological markers of aging, biomarkers. And actually, in this paper, we see that also using these biological markers for diabetes, high blood pressure, C-reactive protein, and cholesterol, we see that these differences between the US and England also remain. So there seems to be, I think this is the moment in which we discover that these differences actually may be real. Maybe it is the case that in this study, the US has poorer outcomes in older age than Americans of the same level of income. Now we see that there have been many studies that have followed this first study by James Banks and colleagues, and this is just one of them, as to give you an example, by Choi and colleagues, in which we see that these differences also apply to functioning, so measures of aging that looked at functioning with ADL or IADL limitations. And it's quite interesting that differences in function also exist across the distribution of income, but seems to be much more marked in the lower income, lower end of the income distribution, perhaps suggesting that it is really low income, perhaps Americans, who at least to a more important extent drive differences in functional outcomes relative to England. Now, I was very lucky to, in those days, I was very lucky to be part of the SHARE study in those days, working with Johan Mackenbach and other colleagues collecting data on Europe. And then with James Banks, Maria Glimmer, and Johan Mackenbach, we were able to extend this analysis on the English and US comparisons to look at the whole set of SHARE countries at the time, around 13 countries in Western Europe. And what this graph shows you is, again, the prevalence of different conditions for the US, HRS, England, and Europe. In those days, I remember the journal asked us to justify why England was separate from Europe. Very lucky we don't have to justify that anymore. But what you see here is essentially that not only Americans have higher prevalence of diseases than the English population, but actually the English population has also higher prevalence than Western Europe as a whole. When you disaggregate countries, you'll see Denmark maybe coming up sometimes upper in the distribution, but we see that actually it's not only a US versus England comparison, but there are really large differences in aging, healthy aging outcomes across all of these high-income countries. In this same paper, we're able to also look at wealth. Again, one of the nice features of the HRS sister studies is the detailed data on housing wealth, financial wealth, and this is total net worth plotted against the prevalence, in this case, of lung disease and diabetes. And again, we see that it is really the Americans, the poorer Americans, in this case, we see a kind of an extreme of groups with negative wealth, but it's really the lower wealth distribution Americans who seem to drive these differences between the US and Europe. Nevertheless, for many outcomes, even rich Americans, again, seems to have higher prevalence of diseases. Now, again, others have extended this work to now look at this question longitudinally, another, of course, of the advantage of the ELSA study. And this is a study, again, looking at the same question, comparing England and the US, but looking at cumulative incidence of death. Also, they have a similar analysis for disability. And again, we see these really large differences between income groups, but also, again, the large difference between the US and English population, especially at the top of the income distribution, but also at the bottom of the income, at the upper end of the income distribution. So both rich and poor Americans seems to have a higher incidence of death and disability than corresponding English population. Now, so what are these comparisons really telling us? And I think we still need to do some work in thinking about this, but I find this paper really useful. This is a paper by Thomas Rapp, Jerome Ronchetti, and Jonathan Sisik in Paris University. And they basically evoke this idea that perhaps in some countries, the distance between physiological age and chronological age is simply larger. So what you see here in this map here is basically the darker, the redder this graph has. It means that there is a larger distance. Basically what it means is that two people with the same chronological age may have very different physiological age. And essentially what this is suggesting that perhaps there is something about the context in the US that make it so that essentially Americans age faster than corresponding Europeans. Some countries have lower distance between physiological age and chronological age, such as Switzerland, the Netherlands, Greece, Sweden, and others have higher distance between the two. So I think it's an interesting kind of way of measuring it, but also of conceptualizing of how the country in which we live might, for some reason that we still don't understand very well, lead us to age faster. And maybe this takes us to the next question, where I think the ELSA studies have been really useful, which is in trying to, of course, ask the question, why do we see these differences in healthy aging between high-income countries? And I want to just refer to two important reports that were commissioned by the National Academy of Sciences that initially were focused on mortality, but they also actually looked at morbidity. And they tried to it was a very systematic study going through all the possible kind of explanations that we could think of at the time. So here you see a series of the explanations addressed in each of the book chapters, many of them looking at behavioral differences. We know that there are differences in obesity and physical activity, for example, across countries, smoking. We looked also at social integration and social interactions. Others look at the health system, and obviously an obvious possible explanation. Maybe for women there is something about hormone therapy. We looked also at socioeconomic inequality and geographical inequalities. And what's I think really impressive about this report is that maybe I'm exaggerating a little bit, but I think Samuel Preston, who was leading this, more or less dismissed all of these possible explanations. For some of them, maybe physical activity, there is something more. But it really kind of concluded a little bit that maybe a lot of these differences in mortality, at least that we see, have to do with the higher level of cigarette consumption per capita over the last 40 years for Americans, for example, versus other European countries. So it seemed to be that smoking emerged as a potential explanation. I think there are two interesting things about this. The first one is that it's telling us that maybe the differences that we see today are really the results of things that happened over the past 40 to 50 years, right? So really to understand these differences, we have to go back quite a lot. But I think what's really interesting is this second report, which actually asked the question of differences in health, but not only looking at older cohorts, but looking across the life course, and actually also children, adolescents, and young adults in the US seem to have higher prevalence of diseases than corresponding Europeans. And in some ways, this report kind of questions the idea that it's just a story about smoking. Maybe smoking explains the difference for some cohorts of women in the US that are currently old, but there seems to be other explanations that lead also to the same outcome for younger cohorts. And so, these reports raise this question, which is one of those things that are really maybe impossible to answer. Might there be some aspects of life, in this case, this report in modern American life, that might explain these differences? And one of the possible explanations that are constantly evoked is the role of systems. And with systems, I think they mean policy. It could be health policy, it could be social policy, social services, education, employment. And this is kind of what this report in 2013 kind of tried to evoke as a potential explanation. So essentially, this leads us maybe to this part of the presentation, which refers to some work that other people like myself have been doing, trying to ask the question, to what extent public policies might be in some ways behind the story or part of the story of why, in this case, Americans have poorer health and shorter life expectancy than other high-income countries. And this is what I like to do kind of in this second part, try to raise this question and link it to this question of public policy and also illustrate the value of ELSA to look at this question. Now, how do we get to understand the impact of social policy or public policy in general to differences in health across countries? One way to do that will be to start by simple correlation. So we look, for example, at expenditures in different areas of policy and correlate them with life expectancy outcomes or health outcomes. If you do that, for example, in this case, you'll see that countries that have had a faster, larger and faster investments in different areas, such as education, tend to have also higher life expectancy. So there is actually a strong correlation between expenditures in education, family, and, for example, mean old age benefits, mostly pensions, and life expectancy. Countries that invest more in these areas tend to have higher life expectancy, also over time. The more they invested, the quicker the life expectancy actually grew. Now, obviously, this doesn't tell us anything about causality, because there may be many things that are correlated with these investments, but it kind of, I suppose you could say, it's an stylized fact that tells us there seems to be something of a correlation that we could explore further, trying to look at other approaches. But to really understand this, we'd really like to understand not only how total investments work, but what actually policy does. And to understand the impact of policies, we really need to look at the specific policies and what policies actually do. And policies, at least in market economies, they have essentially two objectives. They try to get us to behave in certain ways, for example, correcting information asymmetries or correcting moral hazards, all sort of market failures that exist. And some of those policies also aim to achieve the objective of equity, right? So to redistribution of resources in the health system and so on. Now, what I think it's interesting is that these policies always aim to maximize some dimension of well-being. For example, employment, maybe retirement policies, state pension age increases, aim to increase the probability that individuals work longer, but do not necessarily consider health as the outcome. And so I think the agenda that is really interesting is try to understand how public policies, some of which meant to influence health, but some of which do not necessarily aim to influence health, end up having consequences for the health of all the people. And then the second question that is very difficult to answer, I think, is to try to understand how these changes in health called by policies actually contribute to cross-national differences in health. And here you see some of the work, much of which has been also done with the ELSA and the HRS sister studies, looking at different dimensions of public policies that might have impacts on health. Early childhood education, compulsory schooling laws, retirement and pension reforms, family policy, housing policy, and so on. So all of these are areas of policies where we actually still know very little, but the evidence that we have from ELSA and other studies is that they may have important consequences for people's health. So just in these last few slides, I just wanted to give you very quickly a few examples of how we can leverage the use of ELSA and HRS sister studies to get at this more difficult question of how policies influence health. This is a study, for example, that we did looking at the introduction in the UK of the free bus pass, which essentially enabled people who reach a certain age to use public transport for free. And what it shows us essentially is that free public transportation increased the probability that people use public transportation by about 7%, but it actually also improves people's cognitive function. It actually also improves memory and processing speed. So this is kind of a policy that has nothing to do with cognition, but it ends up having positive impacts on cognition. Now, sometimes these impacts can be also quite complex. This is a study that looked at the impact of the increase in the state pension age in the UK and the impact that this increase in the state pension age had in the probability that middle-aged Americans provide care to their parents. And what it shows us is that the state pension age increased the probability that people work, but it also reduced the probability that they supply care to their parents. And what we were able to look at in this study is that this has important consequences for the health of very old people participating in ELSA. Essentially, when an older participant in ELSA, their daughter is not eligible to a pension anymore because of the state reform, her older parents receive less help. And this reduction in help is not actually compensated by other informal or formal care sources. So we see here how there is this trade-off between achieving an objective of getting people to work longer, but that ultimately also has consequences for health that we actually had not predicted. And finally, we've also done work looking, for example, at the impact of the End Loneliness campaign in the UK, which encouraged local authorities to invest in reducing loneliness. And different local authorities took different approaches. Some local authorities were very active to implement programs to target loneliness. Others were less active, and others were not active at all. And we exploit this variation to try to see to what extent these campaigns and policies have an impact on loneliness and mental health. And I think, and I have this finding very often, is that I have a collection of negative zero-effect papers in which basically we see that all of these policies that seem very nice and have really good intentions sometimes lead to very little changes in actual outcomes. And how sad that might be, I think that's also the value of ELSA that tells us about, the impact of public action. Here we see very little changes in the prevalence of loneliness, no matter whether you were in an area that implemented very aggressive programs to end loneliness or whether you didn't. But actually, if we look at the analysis, it does show that among higher educated people, there was a reduction in loneliness feelings as a result of this end loneliness campaign, which is maybe good news for highly educated people, but also shows that some of these policies might somehow increase inequalities. Okay, so I think just wanted to end with a slide thinking about the perspective for the future. So I think really ELSA and the HRS sister studies have helped us to understand and describe differences in health outcomes, but we also need to be more active in linking more policies that might explain these differences and consider policies across really the life course and how they impact age. It's also quite challenging to do this and transform this into an answer to the question of why do we see cross-national differences, because there are many policies that contribute together to these differences, and maybe we need some kind of simulation methods that enable us to do this in a better way. But we also have a lot of work to do to understand differences in a specific outcome. So differences between countries in cancer might not be due to the same reason as differences in heart disease or differences in functioning. So we need to also link specific policies to specific outcomes. So just to conclude, I hope I've given you a little bit of a fair shot of some of the studies that have shown us that cross-national differences in health are large and are real. They apply to all the socioeconomic groups, but are also often larger in the bottom of the socioeconomic distribution. Unfortunately, there is no simple explanation for these differences. Smoking is maybe an explanation for some of the historical trends for women, but behavior alone seems to be an unlikely explanation for all these differences. Again, healthcare seems to be an unlikely explanation for all of the differences. Maybe they explain differences in early life, but they don't seem to be the explanation for older age differences in health. Now, we see from these studies that I show you just a few examples, there are many others also using the ELSA data that shows us that public policies are important for health. But also what I've learned over these years doing this is that it is very difficult to establish that a policy actually changes health, nearly impossible in my experience. Very often we only get an effect of a very specific policy, what we call the local average treatment effect, and it's very hard to say how this policy actually contributes to cross-national differences. But nevertheless, I do think that ELSA and HRS are unique resources that really help us to understand how public policies shape these cross-national differences in health by essentially influencing the environment in which people age. So I think I'll finish there. Thank you very much, and happy to take any questions.
Well, thank you very much indeed, Mauricio, for that very thoughtful presentation of these cross-national issues. We have three experts who are coming up to provide some discussion, to open the discussion on these topics. I'll just introduce, we have David Richter from Berlin, from the Free University of Berlin, fairly recently appointed chair of Share Berlin. David Weir, professor of economics from University of Michigan, who's director of the HRS, and Jinkook Lee from University of Southern California, who also runs the Gateway to Global Aging. And so I guess, are you going to start? You're probably going to kick off. So Jinkook has some slides that she's going to show, first of all. Thanks.
So again, thanks very much, Andrew. Great to be here. And it's really amazing to celebrate 20 years anniversary. And especially in this session, we are thinking hard about cross-country comparisons. So I'd like to just share a few thoughts, echoing a lot of things that Mauricio has already spoke about. And as when we think about the cross-country comparisons, a lot of times we focus on the cross-country differences. But I think it will be also important to think about step back and how we find what's universal about aging processes, especially whenever we look at, especially when Mauricio looked at socioeconomic differences, we repeatedly see the gradients across different countries. Similarly, we see particular risk factors, in this case, air pollution. We see harmful impact on cognition. So whenever we do cross-country analysis, it again re-emphasizes what is really universal and fundamental about aging processes. And of course, we also can see how things change over time. We have seen a lot of changes in terms of longevity. Everybody is enjoying more longer lives. But when we start looking at the disability, we actually see diverging trend. In some countries, disability improves. In other countries, disability years actually increase over time. So then we start thinking about what's driving those different trends in thinking about cross-country analysis. As Mauricio has shown us, we can think about disparities and how men and women across different countries actually observe different level of pension wealth. And we can see gender differences, and most of those gender differences, when economists look at it, this gender difference has been explained a lot by work history differences. But then, once we account for all the work history differences, we again start to seeing some remaining differences between men and women, and we now trying to explain those remaining differences through policies. So I think this, all of us in this room, and together with ELSA, we are trying to think about those, both what's universal and what is different. So thank you.
Thank you very much, Jinkook. David Richter, do you want to just speak from there?
Yeah, thank you. Thank you, Mauricio, for your talk, and also thank you, Andrew, for inviting me here. And a colleague once told me that if you're invited to discuss a talk, you are allowed to be a little bit egocentric, and that's what I will do now. And so I will get back to 20 years ago when I started my PhD, and also ELSA was started. And what we did at the Max Planck Institute for Human Development in Berlin, we invited 160 adults to the lab, 80 younger ones, 80 older ones, and we studied age differences in empathy. And we collected self-reports, we collected peripheral physiological data, and also we did video recordings and coded the facial expressions. And then we draw conclusions about the whole of humanity, because this is basically what psychologists did. Of course, it was an experimental study, and we said it's age differences and not development, but still, the assumption was if you take 160 adults from Berlin, it doesn't matter that much compared to other countries. It's fine. And then the main caveat was that it's age differences and not development. And so I went to the socioeconomic panel study where I could use longitudinal data to study real development. And then we took those 30,000 respondents, and they now approach 40 years of data collection, and we published quite some papers on the development on sleep satisfaction, well-being, risk aversion, also social relationships, and so on. And this was running very fine and smoothly. And then at some point, one reviewer wrote, meh, after all, it's just a single study in one country. And then I realized, okay, something changed now, and I call this the persons in context revolution in psychology. So psychology as a field realized people live in different contexts, and those contexts, they play a role. They influence their behavior and their experiences. And then, of course, you need to adapt. And so we try to do this in our papers as well. And this is also why I immediately applied as the position to become the new director of the Cher Berlin Institute was advertised, because I also want to take part in this person and context revolution and bring it forward and harmonize data collection across different countries. You can do it before the data is collected, like we're doing it at Cher, or afterwards, like Jinkook is doing it. But I think the solution for the future for psychology lies in comparing different persons across different contexts. And maybe this is also true for the other social sciences and the field of economics as well. And how does this relate to your talk, you may ask? So for once, I really like the international perspective and the comparison across different countries. And I think this is really something that we should promote in the future with harmonization. And then there's also another angle, because one of the very first papers that came a little bit as a game changer for the psychologists, at least for me, was a paper on loneliness by Michael Luhmann and Louise Hawkley, I think, in 2016. And they realized that the strongest predictors for loneliness were not number of friends or whether you were single or not. They found that for older adults, it was severe functionality impairments, of course. And for younger adults, it was income. And so for younger adults, the strongest predictor of loneliness was income. And they were a little bit surprised by this. And then they explained it a little bit in the discussion that maybe if you don't have the money, you cannot go out with your friends, and then you feel lonely. But this was the first, at least for me, I think it was one of the first times where psychologists really realized that people living in a society, and they live in contexts, and this has an influence on them. So thank you very much for the talk, and I think this is basically what we should do in the future. Yeah, thank you.
David, would you like to?
Yeah, thank you, Andrew. Wonderful talk, Mauricio. Fun to see the slides, fun to hear your presentation. I want to commend Andrew and team for putting this on your 20th anniversary celebration program, because nothing stops your view of yourself as the center of the universe faster than looking at international comparisons. So to celebrate yourselves in context, I think, is a wonderful thing. It also goes back to what Michael was saying about the origins of ELSA. Richard Sisman and Jim Smith very much had the idea of building an international network in mind, and that certainly included the value of studying other populations as a way of getting additional perspective on health. It also meant bringing in other scientists. So the story of his long recruitment of Michael and then with Michael of others is very much part of their strategy. Andrew gave some examples of areas in which HRS has led the way, others in which ELSA has led the way, others Cher has led the way. So that building of the international network was not just about creating broader comparative data, but also creating a much larger community of people with different perspectives and backgrounds, all of which contribute to the whole. And I think Mauricio, in his work, has exemplified that, and some of that he shared with you today. So the research agenda on cross-national differences, I see as you can approach it from one of two perspectives. One, and this would be more mine as an American, is there's some really big differences, and why are they there? And we need to understand that. And that's driven by the fact that the U.S. Is far behind most of these other countries on health and life expectancy, and falling further behind. And I have these conversations with friends at home who are on Medicare, but are raised Republican, and when I talk about strategies on policy, oh, but that would be socialized medicine, and that would just be awful. And I say, well, the evidence suggests that it isn't so bad, but that doesn't penetrate. The other perspective is that you just want to learn about health. What are the determinants of health? What causes population health? And having a menu of different environments to study allows you to do that. And it seems to me, of course, ultimately those two come together because you need a model of the determinants of health in order to explain these differences. And there, I think, is where this is an interesting challenge. A conventional epidemiological model, this individual is exposed to that exposure and therefore had this outcome. You'll never explain population differences by adding up those associations. You need a framework which allows for externalities in which things affect multiple people and not necessarily just the ones you can clearly identify as having had that exposure, and externalities across diseases, because the U.S., for example, is not just failing on heart disease or cancer, it's kind of across a wide menu of conditions. So I think you can look for things that have externalities. Smoking does to some extent. I think Sam's work on the importance of particularly women in the U.S. Having taken up smoking in much greater numbers than Europeans in the same cohorts, my mother's cohort, is a good example because it has secondhand effects on lots of people, but particularly children of those women. So there's a way in which smoking has those kinds of externalities. But many other things really don't. And that's why I think policy is an obvious thing to look at. And it seems to me a natural for explaining some of the broadly based multiple individuals, multiple diseases that differ between countries. The challenge, and you've fully acknowledged it, is what's the causality, what are the mechanisms, how does it come to be? So there's plenty of work left to be done. Finally, I just felt this talk was a nice companion to James Nasru's excellent talk. So good to see you again, James. And one thing that struck me was to think about how, to what extent do early life inequalities carry with us right the way through later life? To what extent are they offset either by individual resilience or social accommodation? And what are the cross-national differences in that critical juncture? If we all start with a certain amount of inequality in early life, which societies do a better job of mitigating that as people age? So anyway, I thank you, Andrew, for a great topic, and Mauricio for a great talk.
Thank you very much, David. Mauricio, did you want to respond to any of those points?
No, thank you. Thank you so much for the comments. Really useful thinking, but I'm happy to open it to the audience.
Okay, well, let's open this up then to the audience in general. Questions or comments, please. Roseanne, do you want to start and then?
Oh,
yeah.
Thank you. Thank you very much. I very much enjoyed that, and it's important. The reflections of all of you, in fact, are align with what I'm about to suggest, and that's going deeper into the biological mechanisms that might explain some of the differences. The genetic determinants of longevity are dynamic and depend on the environmental history, as David said, with respect to psychology of a given population. And we know that population-specific genes, I was discussing this at the coffee break with someone, actually play a greater role in attainment of longevity than those shared between different populations. So my point is to be mindful of the fact that these population differences may be even more deeply rooted, and that protective alleles, etc., and other biological signatures may be population specific, and therefore not to shy away from making cross-population comparisons, even at a deeper level than the lovely work that you've all outlined.
Thank you. Of course, those sort of cross-national genetic studies are very difficult to do, aren't they, because of the whole profiles of these things. But an important point. Yes.
Hi, I'm Weir from King's College London. Thank you, Mauricio, for this very inspiring presentation. I really like your last slide, where you talk about challenges in doing this cross-country analysis. And one of the challenges that you mentioned is how to harmonize different policies in the analysis, and how to understand, the effect of different policies on people's well-being. Another point probably is even more tricky is to understand, to also sort of incorporate the life history, how policies throughout people's life would influence people's well-being in later life. And I'm just wondering, in terms of methodological innovation or development, do you have any sort of idea or any comments on how we could do, not just to harmonize, policies, in different policies in a certain time point, but also across people's life history and for so many different public policies? So this is basically my question.
Thank you for the question. Yeah, no, that's a really great point. I think Jinkook is the expert on harmonizing policies, so maybe she will have something more to say. But I think to understand policies across the life course, we really need to look at history, and that's what we actually, for example, are doing with Jinkook and colleagues at the USC. Try to collect, for example, data on historical policies on education. We're looking at historical policies on tracking across different countries, starting from the 1930s. So actually, you really need to go into the detail of understanding the policy, which is a work that, for example, epidemiologists or public health experts are very unused to do. So I think we need to put more efforts into understanding the history of policies and how they have changed over time. I think you were asking about how to understand the impact of, for example, historic work histories or people's life histories. And I think what I've learned a little bit from maybe economists is that sometimes you need to use multiple data sets to answer a question. Again, something that we don't do too much in public health. So, for example, to understand the impact of educational reforms, sometimes we need to look at ELSA, HRS, SHARE, but maybe we need to also look at the birth cohorts and combine this data to try to sort of tie the things together that are not in a single data set. So, if I would put at an innovation, I think it's this new tendency now to bring together many different data sets, to link it with registry data from historical records. And then that's how I think we can advance this a little bit, apart from that very kind of somewhat maybe biased, a little bit shot that we get with the life histories. I hope this answered a little bit your question.
Jinkook, did you want to?
Yes, if I may add just a little bit to what we've been currently doing in terms of putting together the policy initiatives. Actually, Mauricio and our team has been working on bringing a lot of details on historic education policy data. And if you can come to the Gateway to Global Aging website, we have also put together long history of pension policy data, so you can compare at country level what kind of reforms has happened in the past. And we are at the stage of developing some of those individual level variables that captures people's eligibility to different pension programs and benefit amount and so on. Our current initiative also includes long-term care policies, so that again allows the investigators to evaluate the differences in long-term care policies and how that influence their behaviors, as well as the choices they have made. And for example, like you can look at like differences in place of death and how different countries' long-term care policy has any impact on those aspects as well. So I invite you to look into some of those policy information deeper. Thank you.
Thank you. Nick, I think.
Yeah, thank you very much. I really enjoyed the talk about international comparisons. And I just wanted to ask you a little bit more about the causation bit. And you know, at one level, you've got on one side, you've got a bunch of countries, and you can say some did better than others. And then on the other side, you've got a big basket of policies, and you can pick out some policies and say, look, these policies were implemented in these countries that have done better than others. And the accusation and the difficulty is obviously saying, well, why did you take those policies? And I wondered if you could talk a little bit about risk factor exposure, and you know, can we start making links between, well, these policies were implemented, you know, taking up your point about historical policies at these times, and they might feasibly have influenced these risk factors, and we know there is an evidence base linking these risk factors to population outcomes. So should we be making more effort to think about mechanisms of action historically over the life course of different policies? In general, and particularly, would that help us with interpreting the decline in life expectancy that we've seen in most high-income countries? Since you know your graphs tended to stop around kind of 2015, which is just when there's been a tail off. So, a two-part question: one, do the mechanisms of action help us interpret the effect of policies? And two, might that be particularly useful looking back over the past kind of 10 years or so, where we've seen a widespread tailing off of life expectancy improvements?
Thank you. Thank you for the question. Yeah, so I think you raised first a question about the selection of the policies that we focus on. And I think it's a really good question because sometimes as a researcher, you like to focus on the policies that you think are the most likely to have an impact on the risk factors that actually impact health. But what I've learned doing work in looking at the impact of policies is that we are left a little bit to the history of policies that exist and the history of policies that have been implemented, and that those changes actually coincide with the time in which the data was collected. So what I want to say is that there are a number of challenges. It's not like you have these policies and you just run your regression model. No, these are papers that take years and years to really understand the policy, to link them to the data, and then that makes it a very slow, I think, work. And that's, I think, why it's important to have resources like the Gateway to Global Aging, in which some of the policy data are collected, and in which they help us to, in a way, link them to the HRS data. But I think you're right that there are many policies. There is some work, for example, looking at the HRS sister studies, looking at tobacco control policies and how they may also contribute to outcomes. But again, there are hundreds of tobacco control policies. It's not easy to harmonize them. So we have a very kind of partial view of what's happened. The same is true, for example, for education policies. We know a little bit about compulsory schooling laws, but we know very little about other policies. We know about state pension age reforms, but very little about other policies that actually probably were more important in transforming the economic well-being of all the people. So I think we need a lot more work and resources and working with historians and political scientists to understand these policies. And your second question, yes, it's true. In this presentation, I didn't talk very much about, for example, the debate about the deaths of despair and the more recent data on mortality. That's a very interesting debate, and I think we have some experts in the audience who may be able to say more about that. Yeah, I think I wanted to focus a little bit on this idea of mortality and health in older age, which I think it's still quite a different debate for the more recent trends related to COVID as well, or related to increases in mortality in the US and in some of the European countries. I think that phenomenon, again, maybe I'm wrong, but I think that illustrates how you can have period effects, so things that happen that may increase these mortalities, like COVID. But for me, that's a different phenomenon than the historical trends that we observe that have very much historical roots. And I think it's important to make those distinctions, but obviously in the data, we're never able to distinguish very well these cohorts or these periods or age effects. But yeah, thanks for the question, because that's a very important area where maybe we need to do more with the ELSA and HRS sister studies. Yeah.
Thank you. Questions or comments? Jen, do you want?
Thanks. That was a really interesting talk, Mauricio. And I think just following up on this point, this really got me thinking about I liked the idea of cross-country comparisons as inspiration because it's hard to look at that data and the US would not be able to say that they can't be doing better. But then in trying to use this for explanation is where I really liked your attention to cohorts too, that we have to, within countries, kind of look back in time, like light from a distant star, but then simultaneously looking at different policy and social contexts across countries. I guess I am kind of overwhelmed at the analytical challenge and, have we effectively been able to use cross-country comparisons for, economics or politics? I think it's a challenge across all disciplines. And so I think it's very illustrative descriptively, and I'm wondering, are you more optimistic about it as an analytical challenge at the end of the day? Or does it kind of, point to some things and give us some hints without really letting us, make that link between, what's actually causing these differences?
Thanks, Jennifer. Yeah, no, that's a great point. Actually, I started to get interested in the impact of policies because of cross-national differences in health. But then, if I can put it that way, I got lost trying to identify the causal effects on policies and forgot to come back to the question of cross-national differences until Andrew asked me to talk about it. So I think it's very difficult to link these two things. And as you say, because we have all these different cohort effects and these different things that influence policy, I think it's very difficult. I think there is a great potential to exploiting differences between countries in policies, but at the same time, the papers, for example, that I shared today, as you saw, there are countries only based on the UK, based on England and the ELSA data, because it's much easier to understand one single policy change. And I think what I think is analytically, but also resource like challenging, is that to collect the data across countries, basically we need to ignore a lot of the specificities. So we looked, for example, one time at maternity leave benefit policies, and we look at how many weeks of maternity leave you have to try to see whether that contributes to women's health. But maternity leave is much more complex than just the number of weeks you get. But somehow you need to ignore and have this trade-off between having a lot of detail and getting something that you can actually link to the ELSA and the HRS study. So I think it's that trade-off that I think it's really difficult. And to be honest, I don't think the work on policies that has been done has really told us very much yet about what explains these differences in health. I think there is still all that linkage to be done. We know some policies impact health, but we don't really know whether they contribute or explain these differences across countries. So yeah, I think that's the situation now.
Thank you. Can I just ask the panel if there are other comments they'd like to make at this stage? If not, I think time is reaching the end for this particular session. Thank you very much for attending this. We've got a fairly extended lunch period because I'm hoping that people will visit the posters, which are in the rooms next to where lunch is being served, and we're due back in here at 1:45. Thank you very much. Thank you all.